Thanks to Nolex and the sponsors for giving us a chance to speak here. My name is Shashi Irukula. I'm a consultant surgeon and a deputy medical director at Ashford and St. Peter's Hospital. We're going to do a double act. Anna Thompson.
Yeah, I'm Anna Thompson. I'm the lead nurse for surgical site infection surveillance at Ashford and St. Peter's, and we'll be presenting together because we work together, and then we are a double acting work as well.
That's right. That's right. So that shows, it's a teamwork. Okay. We just want to share our experience, where we started, how we started, and how we got buy-in from our team and the senior management, and etc. So our journey started with a GIRFT report in 2019. As shocking as it was, we realized there was a huge problem with the surgical site infections. And the data collection was poor, and we didn't have any forum to discuss the problems. And then when we looked at length of stay, we couldn't say whether the length of stay was related to surgical site infections or patient safety. So we started with 4 people: microbiologist, medical director, and a QI person, and the nurse specialist for IPC. Then my medical director kindly delegated that to me, being my boss. And so then we started our journey with introducing various specialty leads for SSIs: surgery, general surgery, colorectal, upper GI, gynecology, orthopedics. Initially, it was a huge problem to get buy-in because we had surgeons, including myself, saying, I don't think we have any problem here. Of course, when you don't collect data, you never see a problem. Once you start collecting data, then everything starts peeling off. So over 4 years now, we have formed a full house surgical site oversight committee, and it's fully functional. We have champions, nursing champions, we have surgical champions, and also ward managers involved in this. And recently, we have presented our data to our Trust Exec Committee meeting. I will talk about that later. So, Anna?
Okay. So, pardon? Yeah, happy? So, can I just see how many SSI nurses are here, or IPC nurses that do collect data for surgical site infections? Okay. And what do you do with that data? Goes into UXA? Stays there? Stay on spreadsheets? Do you do anything with that data? Do you use it for anything? Reporting and? Yeah, good. So your data collection have to be meaningful. If you're just going to collect data and let it sit on a database, you're wasting your time and your money and your resources. That data is powerful, and it can help patients and trusts. It helps us save money. It literally does save lives. But that data, you have to use that data to make a difference. If you don't do that, there's not much use in you collecting the data. Okay, your turn.
So, what's our aim in knowing the rate of incidence? I think what we, from our experience, what we have done, we looked at our rate, and the original rate, as I said earlier, was not accurate. And then when we started collecting our data, I've been bombarded by various committees. How come you have increased your rates of incidence is worsening? But reality is when you have an accurate data, then you pick up problems. That's why your incidence will look higher than before, okay? I'm sure this applies to most of the hospitals across the country. So when I was talking to various medical directors in the region, they do not have any formal SSI oversight committee or data collection. So obviously our rates looked worse compared to the neighboring hospitals. So, and we have looked at the length of stay, and one specialty, just a fracture neck of femur, compared to 2019 and 2022, we saved nearly £200,000 by introducing simple things. We didn't do anything major. We just standardized the practice. We standardized the antibiotic bundle. It was a huge problem. You know, how many of you deal with orthopedic surgeons? I'm sure you can feel the pain, right? So, but it was a painful journey, but it was worth having that journey, going through that journey. So now we have a robust data collection, but I think what we need is a sustainable data collection process. I'm not sure how many of you use a different data collection other than someone calling the patients. Do you have any experience?
I think most people submit to UK Health Agency now. Yeah.
But how do
and
you
use the protocol,
yeah.
the set protocol by that?
How do you collect the data? Is it manual collection?
We will go on their follow-up appointment. We'll follow them up. We'll go into clinic. We'll see them in clinic.
Okay, so that's manual, and then unfortunately, we don't have enough workforce to deal with that in every specialty.
No, we only do orthopedics because that's the mandatory one, so we have to do long bone anyway, so everybody does.
That's
Yeah.
good.
Yeah.
Okay, so we'll talk about what we are aiming for, and what we request our trust management to do in next slides.
Okay. So your aim is to know your rate, and once you've known your rate, is you want to do something, you need to prevent surgical site infections. Okay, it doesn't help you are logging, you've got good robust data and you're logging all of these SSIs, but you're not doing anything on preventing them. So how do we prevent surgical site infections? So I think this leads, you had a very, very good taster from Giles Bond-Smith, and he did all the care bundles with you, and the pathway, introducing a surgical site infection preventative pathway. And guess what? I learned from him 3 years ago. I'm not an expert by any means, but I have learned a lot from other people that have been in this job longer than I am. So, and I think that's what the nice thing about the SSI community is, that we help each other. We are more than happy to help anybody and to give advice, free of course, free advice, exactly like he said, anytime, email, ask, because it's not something that you can go on just on a course and learn how to do. There isn't anything out there, so we help each other. So first of all, there's guidance out there. The WHO, CDC for America, and then back here in the UK, it's the NICE guidance that set out specific things, and it's all evidence-based on how you can prevent surgical site infections. We then use and implement an evidence-based surgical site infection care bundle, exactly the same one as he showed. For each specific speciality, we would go to the speciality, to the consultants, and we would give them a proposed care bundle pathway, and then they can choose what they want on that and what they don't want on that. Also remember, different trusts, your money and your finances might be different, your resources might be different. So where I can use ChloraPrep in my trust, Beth can't use ChloraPrep. So we need to put something else in place for her. So it's very much, there isn't a set standard. You choose from the guidance what there is and you make it work for your trust and your specifics and your population, your patient group. So we then implement those speciality-specific pathways in each of our specialities. And very important, and this is where it helps to make build really good relationships with the industry, is teaching and training. Because of resources in the hospitals, and certainly in my job, I'm one person, I can't do all the teaching and training in the hospitals. And sorry, I'm on Clara Prep, but I keep looking at you, Beth. And Beth. But if you don't use, it's an expensive product, but like he said, it works. But if you use it wrongly, you are wasting money and you will not get the benefit of it. So teaching and training is, in anything you do, really, really important. If your staff aren't confident in what they're doing or how they're using products, you might as well not even have implemented them because you will not see the results. Awareness. So when we started the whole program, I don't know who got the most questions, but everybody kept asking, what is SSI? Who are you? What are you doing? Oh, are you infection control? And I work a bit different. I sit under surgery, not under IPC anymore. But very little people, even though they've worked in surgery for a long time, didn't know what surgical site infection prevention was. So we realized that in our trust, in order to get buy-in and get people to work with us, we had to raise awareness. And we did many things to do that. We did SSI awareness days, we had QASH teaching days. The most recent one was in September last year, where we had over 400 consultants, junior doctors, theatre staff, and nursing staff in surgery attending SSI Awareness Afternoon. We had speakers, Prof. Mike Reed, Ms. Anne Poulieblanc, and some of our own, we presented some of our own success stories and had our own consultants speaking. We have SSI link nurses on every ward where we do training every year for them. So awareness is very, very important. If they're going to ask you what is SSI, they sure won't know how to prevent them. Or the importance, and I think that was the big thing for us, was we had to make staff realize why are we on this all the time? The impact for patients. What's the patient's journey in this? How bad this is for them? The cost, bed days, all the struggles. And then lastly, accountability. So this is a difficult one because there's always a few things to be said about that. But how do we feed back to our specialities their rates, how they are doing, and what governance do you have around that? I think it's very important to discuss and let the specialities take, and this is Giles Bondsmith and his whole process there is a perfect example of how a speciality take responsibility for their data, for their rate, and how they fix it or improve it. So when you're going to start doing your quality improvement process then, where do you start? So first of all, you need your baseline data. You need good, robust baseline data. All of you that collect data for UXA would know everything you need. Important, your 30-day, which we know now, can be actually longer than that, 30-day post-op surveillance. And that can be problematic. That's very labor-intensive. Do you send out letters, which you don't have a really good return rate on? Or do you do phone calls, which you have a good return rate on, but you need a lot of staff and resources to do that? Or do you look at digitalization? Because that's probably, that's probably the future, isn't it? Second thing is try you're not going to fix a trust in a year. We tried. It doesn't work like that, apparently. Start small. Pick one speciality that you know you can have good data from, and preferably try not to do colorectal because it's very complicated. Something that's a little bit easier and more straightforward. And then ID, the speciality that is actually engaged. It doesn't help, not that our breast isn't engaged, I'm not saying that they are lovely, but it doesn't help I choose breast, but their rate is 2%, and they're not really engaged, they feel they don't need to do anything. We go to C-sections, and you just need one consultant that's really engaged and say, this is unacceptable, I don't want to stand for this, let's change things. That's all you need, is that one consultant. And then very, very important is to set achievable targets. If you set a target of 2% or 5%, that's fine. It doesn't have to be 100% or 50%. We're going to halve it in 6 months because it doesn't, it's not achievable. If it's not achievable and you don't get that, then you're just not going to feel, the staff aren't going to say, well, why are we doing this? We're not even reaching the target. So think very, very careful when you set targets because, as we know, management will hold you to those targets. And if you set them and you don't make them, then you're not good. So, the thing we used was the PDCA or SA, as the NHS would know it. It's just the stages from planning and implementing. So first stage is planning. Now, I cannot emphasize enough how important it is to spend time on your planning stage. Because I have learned quite a few lessons from rushing this stage and then getting to do and check and have to go back because it failed. So when you have people working with you, make sure that you have people that read things properly, or try and get as many diverse people in your team, because everybody will have a look on a situation out of a different angle, and it will make your thinking much easier. Schedules, again, when you look at your schedules in your planning stages, don't try and rush things. Don't think, 6 weeks and all will be over. Give yourself some time, because usually there's a bank holiday coming up or a doctor strike or something, and then by the end of the week, you've run out of all your time. So give yourself a lot of time. At the do stage is once you implement any changes that you've made. So say, for instance, we wanted our patients were all cold, everybody was cold reaching, our data told us that our patients in theatre were all cold, and now we have to implement the warming blankets. So when we implement the warming blankets, we have to collect data after that again. So you've implemented, you've checked that everything is running properly, and all the patients are getting them. Now you collect your data again to see whether that had any effect at all or not. In some cases, you'll implement something and there'll be no effect. And that's how it is. And then you need to make that decision whether you can keep it or drop it. Okay. We check and we compare results. That's what I was just saying. You compare the before and the after. And then communicate your learning. It's very, very important. Sometimes when we get to the last bit of the cycle, you're tired and you've had enough and you're just glad you're finished with this project because before the next one is starting. But it's very, very important to communicate and everything that you've gathered and your learning. And there's somebody we always forget, and it's the staff on the wards, and I'm very guilty of it. We always forget the staff on the wards. We'll go and say to the surgeons at the MDT, we'll present everything and say, oh, this has gone so good. Management will know about it. We'll even put something out on Twitter. But we forget about the staff that actually did the work, the ones that had to put the blanket on, the ones that had to take the temperature. We forget about them. So please, when you do any improvement, remember them, go back to them. Say to them, look, do you know that trial that we were doing here? This is the result. This is what your hard work did, and this is the consequences of it. So I'm very much I never worked on the wards, but it's something that I've picked up in the last 4 years, is that we keep skipping them. Something else we use in our trust is driver diagrams. So this is for management. But also, it's to tell them what we are doing and why we are doing it and how we are doing it. But equally, it's for you and for yourself and your team to keep track. Just to have your vision there, know what your vision is and your aim. And then what's the drivers? So for surgical site infections, when you look at the care bundles, it's set out in pre-op, intra-op, and post-op. And then for the specific care bundle, I included environmental causes as well. Being from a theatre background, I think I always will go back and blame theatre first. So then you look at your secondary drivers, and that is what Giles Bond-Smith was speaking about and telling you about. Pre-op will be your body wash. Do we wash patients or do we make them have showers? And your warming. And then your change ideas. How am I going to do this? What am I going to implement to change this? Okay, to get the ideas across. Okay. Oh, Gilead, I've got another one. Okay. Sorry, I thought it's your turn now. I'm hot. So when you do implement your different care bundles, I would suggest, yes, this will take longer, but I will suggest to implement them one at a time. Implement something, implement the warming blanket, give yourself 3 months, implement ChloraPrep, give yourself 3 months, implement Suture Plus, give yourself 3 months, implement Pico 7, give yourself 3 months. Why do I want to do that? Yeah, not everything's going to work for you in your setting. We are all different. Our settings are completely different. There are some things that's going to be vital for me that work perfectly, but Beth, it's just not going to work for her. Or it'll be the 1% it dropped doesn't just justify the £500,000 we have to spend. Okay, so when you implement things at stages, this is what you're going to see, and you can evaluate and say, we dropped 1%, but I've spent 500,000. It doesn't make sense to me. Okay, so that's just something we found that helped a lot. Oh, this is yours.
I think one of the perks of being boss is you talk less.
He makes me work. That's
So, so I think going back to our experience of implementing each bundle, every care bundle, we had different problems. Pre-warming blanket. How many of you use pre-warming blankets in your trust? Looks like only few. It's nearly 2.5 years since we implemented pre-warming blankets, and I still come across patients, coming with a pre-warming blanket somewhere in the different parts of the body, like on feet or head or somewhere else. But we used to see that more often in the beginning, but now even every member of the theatre team is aware of importance of pre-warming blanket, and they keep asking each other, why is pre-warming blanket not on? Which is a good thing, because I think the care bundles, importance of doing it at in stages, we need to remember for every change, it's a painful journey and it takes a long time. And that's one vital point. So this is the specialty we chose, which is the cesarean sections. And as Anna mentioned, we found a brilliant surgeon who had a good insight into the problem. And then they were talking about, Trust was talking about, before my time, they were talking about, how the cesarean sections, post-cesarean sections incidence was so unacceptable because it was around 24%, wasn't it? 24%. So every fourth patient who had cesarean section at our trust was at risk of getting serious infections. It could. So we started with.
At that stage, we were 16.3%.
Yeah. So 16.3, but that was before we collected data. Yeah. So when we started collecting data, then it was quite clear. Actually, it was 16.3, and then we implemented each care bundle. Chloroprep, started with chloroprep, and then vaginal cleansing, and Hebe wash, and then didn't see great reduction of incidence, and then we suddenly started seeing spike of infections, and there was a push for Suture Plus. Looking at the evidence, Suture Plus, if anyone from J&J, please don't find it inoffensive, okay? There is only one paper we saw, and based on that one paper, NICE issued that Suture Plus can reduce infections, which is controversial. I don't want to discuss any more on that. So what we thought, we engaged the industry in buying Suture Plus. It became financially unsustainable to implement Suture Plus across all specialties. Then we decided to implement it in cesarean sections. And as you can see, after that, there is not huge difference between surgical site infections compared to other care bundles. So this is why it is also important to implement care bundles in stages. Then you know the impact of that care bundle, then you can work on those which are effective. So we have gone through a painful process, and then we are in a bit of a celebration mode. So we published our data in various journals, and our gynae team have been nominated as Best Staff Achievement Awards, and then we talk about our success, and we don't have any hesitation to boast. So shout out, publish, share your learnings. Make sure everyone is aware of why you're doing it. It might sound a bit boring to them because everyone thinks surgical site infections is not important, but it is important for you, for the patients, and for the trust, and whole NHS, I suppose. Use your results to get others involved. So what we are trying to do is we are trying to set up a webinar across our ICS, inviting DIPSIs of various hospitals and the medical directors and the infection control team, and also involving the GPs. It is quite crucial, involving the GPs, because anyone, or not, courtesy of COVID, most GPs don't see the patients, face to face, and it has become norm that, they have a telephone consultation. They can't see any wounds or anything, so they just prescribe antibiotics. Is that considered as a surgical site infection? May not. So that's why we need to start educating every stakeholder